readmission penalties. So we knew we were going to have to work with the hospitals because they didn't have anything in place to help prevent those. They did have some things, but it looked like it wasn't as successful as they had hoped. We looked at our high volume calls or loyal customers or frequent flyers, whatever you want to call them. And then I looked at mortality and morbidity in our area. And I utilized our State Department of Health that collects all the data on that. And it's their ERC or Epidemiology Resource Center. And that was excellent, got a lot of data out of that. Really understood what was going on in our community. So we had 5 areas of risk that came out from that. We had quite a bit of hypertension. And then we had a lot of falls and social service needs, which we found out that's mainly what our program ends up being utilized for. Flu and pneumonia for at-risk populations, so our children and our older adults. And then we were looking at patient readmissions to the hospital. So these are the patients that didn't qualify for home health. And I know that's a big concern for a lot of the home health care nurse groups, that they didn't want us taking over what their job was. But we're catching those patients that do not qualify for home health care. And then behavioral health issues. And this was extremely huge, but we found out that my bosses and the community were not ready to tackle that at the time that we were doing this program. And that was right around 2014 when we started doing development. And I'll talk about it later at the end of this slideshow, that we've had some things that happened in our community, especially around teenage suicide, that has really brought this to the forefront. So we're doing some programming around that. So some really neat stuff going on. So coalition building. So we knew that we had to get a bunch of groups together to make this work and to get buy-in from the hospital, from the community. Some of the groups that we work with, Health Call, we utilize them for our EPCR that we use for the program. And they also have some clinical people that help us out with program development that have done some of these things in the hospitals before. Community Health Network, that is the hospital system that actually decided that they wanted to utilize community paramedicine for certain health populations, mainly around congestive heart failure, and that's really the big part of the program that I'll talk about today, what we're doing with patients with heart failure. We also look at Aspire. Aspire is a group that takes care of our behavioral health issues within the county that we live in. So they kind of organize the care plans and who those people with behavioral health issues, who they're seeing. Also Good Samaritan Network and Partnership for Healthier Hamilton County. We utilize this group in our community. They help organize services that are out in the community and help advocate for services that are needed. So we created a partnership with them to help bring those issues to the forefront to legislators or council members and at the county level as well, so that we could get funding for projects that are needed, especially around like transportation is a big issue. And then I've got the International Association of Firefighters. We have the union that we work with for services that we contract with the fire department. So I knew I had to have them on board to utilize our hours for this service, because it's outside of our normal scope of practice, providing EMS service and fire service for the community. So Community Health Network is who we ended up partnering with. It's a large multi-service health system in Metro Indianapolis. The main hospitals that we work with are Community North, Heart and Vascular that takes care of all the cardiology for the north side of Indianapolis, and then northern suburban area. And then their home health care, which we utilized for some of our falls prevention programming. And then behavioral health, and that is really starting to come to a forefront now. Community behavioral health actually has the beds for those patients that need in-hospital care for behavioral health issues. So program development, we got together a work group within Community Health Network from multiple specialties. We wanted to use evidence-based medicine and evidence-based assessments. And we wanted to make a seamless transition from hospital to home. That was really important for us, because we ended up noting that a lot of patients when they got this education in the hospital, all they heard was, "I'm going home." And everything else that the nurses, pharmacists, dietitians tried to teach them was lost by the time they got home. So you can see a few of the groups that we got together. Like Touchpoint is like a social services group within community health. We worked with the heart failure coordinators to help with the programming so that we could make sure that we were getting the right information to those patients. We got marketing involved because we wanted to make sure that we could get the project out to the public in a nice fashion. And then as well, social work, we brought those in because we knew that that was going to be a big need. So we also brought in the clinical director of operations for Health Call, and they actually had done some of these programs before, not necessarily called community paramedicine, but it was with the nurses in the hospital. So some of the things that we did, I know another group had talked about how they find patients that qualify for the program. We use LACE, which is a systematic approach to identify at-risk patients for readmission. We also use teach-back method, which is, there's some trials that show that that helps with 30-day readmission problems, and we also use zone educations. And I've got some examples of those so you can see those. So the LACE index, we look at length of stay, their acuity of admission, whether they came through the AD or the ED, or elected to come in and then they were admitted. Comorbidities, and then ED visits within the last 6 months. And that provides an index of risk for patients. So here's kind of the LACE index. And what we do is we don't have to do this on paper or anything. We use Epic, very similar to Cerner, and it actually runs the patients through the program and then selects those patients that fall within the risk pattern that we're looking for. The other thing we do is for the teach-back method, we actually have, this is a 3-week course that we put through Health Call that all of our community paramedics have to go through prior to even going through the education for disease management and medication reconciliation. And this actually will teach, how to build that rapport with patients, how to coach them, and so that they want to learn to manage their own disease. And this, I will say, is probably the biggest thing I do for our patients, especially those patients in heart failure and COPD. We use the zone process to teach them how to manage their disease based on their care plan. So basically, the top portion has things that the patient can do every day to stay healthy, right? So what we want them to do is we want them to stay in the green zone. So we look at things like they don't have shortness of breath, no swelling, no pain, no weight gain, no chest pain. And so they understand if they stay within this green zone, they're doing very well, right? So, and then we kind of list some things that they can do to continue to stay in those green zones. What we want to do is if they start to have exacerbation of their heart failure, we want them to catch it early on in the process. So we teach them about this yellow zone. So we look at things like weight loss of 5 pounds, weight gain of 2 pounds in 1 day, or weight gain of 5 pounds in 1 week, worsening lightheadedness, tiredness, all these signs and symptoms of heart failure, these early signs and symptoms. And then we coach them to actually contact either us if they want to, their heart failure coordinator, nurse practitioner, or doctor, and actually talk to them about the symptoms they're having. And we've actually found that by doing this, we do medication changes in the home. We just add in extra LASIK and maybe potassium, and it prevents these patients from actually going to the hospital and being readmitted because we catch it so early. So, and then we wanted to understand that, if for some reason you do pass that yellow zone, when to utilize 911 service or 999 here. One of the things that we are doing, we have a toolbox to actually teach this. This is not a validated process yet, but we're actually validating. The patients actually take a survey after we go through the process, and then the educator actually does a survey as well. And the hope is that we can validate this, make any changes if we need to, if the patients aren't getting the information that we want. out of it. But we teach them the zones. We talk about the low sodium diet. We actually teach them how to read the food labels. We teach them how to shop in the grocery stores. You know, most of them tend to shop right in that middle section where they put all the processed food with all the hidden sodium. But we teach them how to actually mitigate that and, you know, start to get more in the fresh fruits and vegetables. And then the low fluid diet, most of our patients are on a 2-liter or less diet. So we actually kind of show them what that is, which you would be amazed, especially in the US, we have an issue with serving sizes that we don't really understand what those are. Our plates keep getting bigger. And so do we. So implementation of the program, we came up with a process flow so that we could understand how this was going to run through the hospital, get the patients to the community paramedics, and then how we were going to communicate with all the people that were involved with this patient's care. We did education for heart failure coordinators who are our transitional care nurses. They are, I always call them the gatekeeper for our patients because they're the ones that actually find the patient for us, talk to them about the program, and hopefully get them signed up. And then we did education for our community paramedics. And then we had to do a City of Fishers ordinance and a business agreement with the hospital as well that's not on there. So the process flow, I'm not going to go through all this, but honestly, it's confusing. And so we had to find a way to make this easy, right? To make this data flow and the communication flow between all these providers. And we did that with our electronic patient care apparatus. And I have a picture of that later. Education for the heart failure coordinators. We wanted to make sure that they understood the process flow and then how to do the data input on our electronic data capture through health call. Because there's a lot of communication that goes with through the electronic data capture system because the hospital did not want to give us full access to Epic. So we have read-only access for those patients so that we can see the medications that they're on, their care plan. But they did not want us to be able to chart in there. So we had to have the heart failure coordinators understand how that works. The other thing that we can actually do with this as well, that we'll add later on, is we'll do education for the nurse practitioners and the cardiologists because we have a way for them to sign in and look at progress notes for the patients that we're following for the 30 days. The education for the community paramedics. When we started the development, there were not a lot of programs out there, so we actually had to do our own education process. So we taught them about the process flow. We made them go through the education for the teach-back method, disease management that was dictated by the cardiologist and the nurse practitioners, medication inventory. So we brought in pharmacists from the hospital, and they provided education for us on how to coach patients for medication adherence. And how to organize their medications, and then to make sure that they were not taking anything that was not on their medication list from the hospital. We taught the EPIC system, which is the electronic health record system. Some of those are difficult to navigate around sometimes to find out what the patient's care plan is. So we wanted to make sure that they understand how to manage through that. And then the health call system and how to manage our patients throughout that. We also, because we wanted to make sure that people understood the competencies, the community paramedics, so what we did was we actually did core competencies to make sure, I don't know if anybody took the old ACLS where you had to sit in front of all the cardiologists and talk about how you were going to implement ACLS protocol before, but it was very similar to that where we had to actually sit down and talk through all the processes that we were going for and had to check off all those competencies. This is our ordinance that we had to go through. And one of the pitfalls that we had going into this when we drafted this was we actually had one city council member who didn't want us to do the program because he sat on the board for the Visiting Nurses Association who does a lot of home health care. So we utilized communities, home health group, and some of our doctors to come in and actually talk with him so that that he and that group would understand that that is not what we were doing. In fact, you're probably going to get referrals from us and have more patients. But anyway. The other thing before I move on too is we had to do an agreement with the hospital, business agreement, and I will tell you that is the longest process. Sorry, John, but and John, all the lawyers involved, to get those things through, it's a long process. So data collection and analysis. So I wanted a data system that could actually track patients for 31 days and beyond. Because I'll show you what the schedule looks like, but we also follow patients once I call it graduation, through the 31 days without getting readmitted. I offer for free to follow up on them once a month just to make sure that things are still going well, see if there's any other needs, and especially around the social service needs. I wanted to be able to assess do the assessment in the data collection and analyze that data within the system, and I'll show you some of those reports that we get. I wanted something that was easy to use that I could teach any of my medics, even some of them that are challenged with computers. So, and then I wanted it to assist in managing large amounts of patients with a small staff, because I don't know if anybody else is like me, but I'm only allowed to have 2 community paramedics, and I have to see quite a few patients, including my other duties. So this is the health call program. What we end up doing is each visit, it'll actually prompt you that you have a visit coming up. You select the patient. It's got a checklist tab on there, so it shows you exactly what's going to happen in this visit prior to going to the visit. And then it's got a dialogue prompter, so whether you're talking on the telephone or actually talking to the patient, I wanted the visit to be the same no matter who was conducting the visit, so it gives you ideas on how to ask those questions. So we get the best data out of it. We do the assessment form, and so we collect everything from vital signs, home safety, patient's weight, so we can calculate that within the system, and anything else, other social needs that are going on in the home. And then we can actually chart in the notes section, and all of our care coordinators can actually see that information as it happens, because this is all cloud-based. And then we've also got the actions section, which kind of shows what things you did within that visit, what type of visit it was, did you refer any sources, did you talk to any of the care providers, and then you can go back and look at that data and see if things were fixed. So this is our 31-day schedule for heart failure. So you'll see day 0, basically what you're doing is the patient is placed in triage by the transitional care nurse. So we get a notification that there is a patient in there with our goal of being within 72 hours of discharge, contacting that patient. We did that because we have quite a few patients that get discharged over the weekend when we're not in the office. Once we make the first call and we get the first in-home visit scheduled, day 1 is considered the home visit. So we go in and we do a full assessment in the patient's home that usually lasts anywhere from 1 hour, and sometimes it goes up to 2 hours, because we find that a lot of these people are lonely and they want to tell you their story, and it's all part of building that rapport with the patients. And I'm actually getting better at it as we go along, so it doesn't take quite as long as it used to, but we definitely do a thorough assessment with the patient. Day 2, we do an automated survey. So I have a phone system, calls up, says, hey, this is Lisa. It sounds like one of my assistants calling, and they actually do surveys. So the day 2 automated survey is more like, did the paramedic know what he was talking about? Did you feel like you got all the information? Go ahead.
Is that a voice conversation, or is it a press button 3? Or?
So it's a push button. So currently,
elderly people, that they can cope with that?
yes, yeah, we've actually had high utilization on those reports. Yeah, because I know that's always a concern. And I actually purposely, in the home visit, I talk a lot about the surveys, because this one's important, but the real important one is that day 31 assessment for the overall care that they were given. So, yeah. We also have phone assessments where I just actually call the patient and do a similar assessment that's over the phone. and really just coach the patient through things that are going on. We talk about those zones again. You know, what zone were you in today? Did you take your weight? What was it today? And then if they had a weight gain of whatever, 2 pounds overnight, then I can coach them through that process at that time. And we have found that has been a big help because a lot of these people feel intimidated to talk to the doctor or nurse practitioner. So we give them cues on how to talk to them and speak their language so that they can actually get the message conveyed. I know we've talked about some of that, the communication that happens. And then once again, day 4, we've got automated assessments. So the automated assessment asks a lot of the same questions too. A lot of them are yes, no, 1 or 2. And then there are where they can type in their weight and their blood pressure. And the system actually calculates for me if there's any issues, and an edit will fire if they've exceeded any of those edits. Sends me a response that says, hey, one of your patients is having an issue, so I can log in and I can go to that assessment, look what's going on, call the patient, and make sure that they contacted who they needed to. So, and then the rest of them, automated assessments, and the day 31 is a survey assessment. Once again, very important to find out how we're doing out in the field. So some of the things that we look at, some of the reports that come out of the program, I want to know about adherence. So is the patient, are they following their low sodium diet, low fluid diet? Are they taking their medications? So I can see this regression over time to make sure that we're doing all right, because if I see a dip in this, I want to know why is that, so we can start looking into that. And then also the well-being for patients, because I think that's very important in this. And that just kind of looks at their overall health and how they feel. So some of the data that we're starting to get out of this now, fairly even on sex of patients, 57.14% male, 42.85% female. Average age for males right around 75.6, females just a little bit over 74 years of age. You can see these are the admission diagnosis of the patients that came in to the program. This does not include all their comorbidities. Turns out we're seeing really sick people. And then the one that the doctor that's working on this with me really wanted me to share was our 30-day readmission data. So in 2016, CMS released data that showed about 29 or 21.9% of patients are getting readmitted with heart failure. We had 7.14% of our patients were readmitted. So we think we're on the right track. We don't have enough in yet to really make sure that that's an absolute number, but we're hoping that within this year we'll have enough patients that we can actually publish this. So that's 16. Yep. So early on in the process. So, and we are working with an extremely small hospital at the time. So reassessing community risk. So what we decided with that is that every 5 years we were going to look at all this data again and find out what's going on in our community, if it's changed. When I started on the job 13 years ago, our average age in our community was right around 37 to 38 years old, and we are continually aging. And a lot of families are bringing their parents into the community. So we know that our demographics are changing. And then if we have any significant changes in policy, which I've seen a lot of slides up here that show Donald Trump up here. So we have a new administration, and they vowed to repeal the ACA. So we know there are changes coming down. We just don't know what those are yet. So we want to make sure that we leave some flexibility that if things change tremendously, that we can reevaluate and make sure that our program is providing what our citizens